Dear friends, today we are going to discuss about the amyloidosis. What is amyloidosis? Amyloidosis is basically extracellular deposition of the insoluble fibrils from abnormal folding of the proteins. So, what is amyloidosis? Amyloidosis is the extracellular deposition of the fibrils from abnormal folding of the proteins. So this is the amyloidosis. So if we talk about the kidney, in 1.5 to 4% of the kidney biopsy, basically we see the amyloidosis finding. Now, how the patients of the amyloidosis present? If we talk about the clinical manifestation of the amyloidosis, so it depends on which organ is involved. For example, if the kidney is involved, the patient may present with the nephrotic syndrome, the patient may present with the chronic kidney disease, nephrogenic diabetes insipidus, renal tubular acidosis type 4, etc. So if the kidney is involved, the patient may present with the renal tubular acidosis, nephrogenic diabetes insipidus, CKD and nephrotic syndrome. If the heart is involved, the patient may present with the non-ischemic heart failure, the patient may present with the restrictive or dilated cardiomyopathy, or patient may present with the AFib. If the nervous system is involved, the patient may present with the peripheral neuropathy, may present with the carpal tunnel syndrome or orthostatic hypotension. If GI tract is involved, the patient may present with the malabsorption, may present with the ulcers, may present with the macroglossia, etc. If the joints are involved, the patient may present with the arthralgia. If there is abnormality of the coagulation, the patient may present with the easy bruisability, the patient may present with the raccoon eyes, the patient may present with the deficiency of the factor 10. So it depends, the clinical manifestation depends on the organs involved. Now, how do we diagnose? How do we diagnose the amyloidosis? To diagnose the amyloidosis, basically we can do the biopsy, fat pad biopsy, or the biopsy of the involved organ, and we can go for the Congo red stain under polarized light, and what we see the apple green by references. That is the characteristic of the amyloidosis, as we know all. Now, if we see the light microscopy, and what we see, the glomerulus has deposition of the amorphous hyaline material. So in light microscopy, we see the glomerular amorphous hyaline material deposition. If we see the electron microscopy, we see the randomly arranged fibrils. We usually see the randomly arranged fibrils. If we talk about the amyloid type, we can do the immunofluorescence staining to know the type of the amyloidosis. But the gold standard is the mass spectrometry. The gold standard is the mass spectrometry. Now, if we talk about the renal amyloidosis, the most common renal amyloidosis are AL, AH and AHL, and 85% of the cases of this type of amyloidosis are found, AL, AH and AHL. In 17% of the cases, in kidney, basically AA amyloidosis are found. In 2.7% of the cases, the ALK2 amyloidosis are found, and in 1.5% of the cases, AFib amyloidosis are found. So if we talk about the renal amyloidosis, so 85% of the cases are found basically of AL, AH and AHL. In 7% of the cases are found AA amyloidosis. In 2.7% of the cases are found ALK2 amyloidosis, and in 1.5% of the cases are found AFib amyloidosis. Now we come to the AL amyloidosis. If we talk about the AL amyloidosis, basically the precursor is the monoclonal either kappa or monoclonal lambda. Kappa is usually in 20% cases and lambda is usually in 80% cases, and these are produced by the monoclonal plasma cells in the bone marrow. These are produced, these monoclonal kappa and lambda, basically these are produced by the monoclonal plasma cells in the bone marrow. So basically these are associated with the multiple myeloma. The concomitant multiple myeloma can be associated in 10% of the cases if we talk about the AL amyloidosis. Now, the local form of this can be the plasma cells, as we discussed. In about 10 to 12% of the cases, the local involvement of the plasma cells. Besides this, the local involvement of the maybe GI tract, maybe larynx, maybe skin, maybe respiratory system. So the local involvement of the AL amyloidosis may be the plasma cells and maybe the GI tract, larynx, skin and respiratory system. Now, systemic form, basically the involvement of the AL amyloidosis is the heart, kidney, liver and nerves. If we talk about the clinical feature, the patient may present in AL amyloidosis like CKD, may present with the end-stage renal disease, may present with the nephrotic syndrome, may present with the proteinuria, edema, swelling, etc. Now, how do we prognosticate? So to prognosticate, we are supposed to take a renal staging system for the prognosis. In AL amyloidosis, we call the stage 1 when proteinuria is less than 5 gram and GFR is less than 50. If the proteinuria is less than 5 gram and GFR is, more than 50, then it is basically the dialysis after 3 years, chances of the dialysis after 3 years may be nil. So if the proteinuria is less than 5 gram and the GFR is more than 50, then possibility of dialysis may be nil after 3 years. This is stage 1. In stage 2, if the proteinuria is more than 5 gram and GFR is more than 50, then the possibility of dialysis in next 3 years may be 7%. If we talk about stage 3, if the proteinuria is more than 5 gram and the GFR is less than 50, then the possibility of dialysis may be 60%. So these are the staging system of AL amyloidosis to prognosticate. Now we talk about the treatment. If we discuss about the treatment, so basically we are supposed to check if the patient is eligible for the HSCT, auto HSCT or not eligible. If the patient is eligible, then we are supposed to do the auto HSCT with high dose melphalan or standard dose melphalan with dexamethasone. So if the patient is eligible for the auto HSCT, then we are supposed to do the auto HSCT, or with auto HSCT we are supposed to give the melphalan high dose. Besides this, we can also give the standard dose of the melphalan plus dexamethasone. Now the patient is not eligible for HSCT, then we are supposed to give the melphalan plus dexamethasone or Cybord. Cybord, as we know, the Cybord regimen, the cyclophosphamide, bortezomib and dexamethasone. Besides this, we can give the daratumab. This is the human monoclonal antibody against CD38 on plasma cells. So basically, in case of refractory cases, if the disease is refractory, then we can give the daratumab, and the daratumab is basically monoclonal antibody against CD38. Now the next comes the AA amyloidosis. The precursor is the serum amyloid apolipoprotein A. Basically, this is produced by the liver and vasculoendothelial cells, produced by the monocytes, macrophages, and induced by the inflammatory cytokines. Inflammatory cytokines like interleukin 1, interleukin 6, and tissue necrosis factor alpha. Now, this is the reactive amyloidosis, and reactive amyloidosis to chronic inflammation like rheumatoid arthritis, Still disease, inflammatory bowel disease, familial Mediterranean fever, and IgG4 related disease. So this is the reactive amyloidosis to chronic inflammation or chronic any inflammatory condition. If we talk about the chronic infection, it may be related to osteomyelitis, bronchiectasis, or it may be related to IV drug abuse. If we talk about the neoplasm, it may be related to the renal cell carcinoma and lymphoma. Organs involved mainly are the kidneys, GI tract, heart, and autonomic nerves. So this is the AA amyloidosis. Treatment is treat the underlying cause, and tocilizumab and canakinumab is also advised. The tocilizumab is the anti-IL-6 receptor antibody, and canakinumab is the basically anti-interleukin 1 monoclonal antibody. Now the next comes the ALK2 amyloidosis. ALK2 amyloidosis is the precursor of this protein is the abnormal protein. The precursor of this abnormal protein is the leukocyte chemoattractic factor 2, a cytokine that is produced by the liver, and this is produced by the hepatic upregulation. And the organs involved basically are the kidney, liver, and heart. And the patient may present with the CKD, proteinuria, and end-stage renal disease. So this is the ALK2 amyloidosis. AFib amyloidosis. The AFib amyloidosis, the precursor protein is the fibrinogen alpha chain, which is synthesized by the liver. Autosomal dominant mutation with variable penetrance, and the prognosis is poor. So this is related to the autosomal dominant mutation with the variable penetrance, and that's why the prognosis is poor, and the precursor protein is the fibrinogen alpha chain synthesized by the liver. Now ATTR amyloidosis. ATTR amyloidosis, the precursor protein is the transthyretin. Transports basically the tetramer protein that carries the T4 and retinol binding protein. This is the transport protein. This is the transport tetramer protein, transthyretin, which carries to the T4 and retinol binding protein. 90% this is produced by the liver, and this is the common form of the hereditary amyloidosis. Organs involved basically are the nervous system, heart, kidney, and GI tract. And last comes the AA2M amyloidosis. The precursor protein is the beta 2 microglobulin. Basically, this is filtered by the kidney, but when there is the end-stage renal disease, the kidney is not able to filter this, and these are deposited in the joints. So this is responsible for the carpal tunnel syndrome with the articular structure related issues and periarthritis, and basically this is cleared by the high flex dialysis membrane.